This was presented yesterday by Professor Mathai, but just there were a number of people who are not present, and that's it shows where the study is taking place. That's Kisumu and the funders of the project. So in terms of introduction, this paper addresses one of the social determinants of mental health, and that is intimate partner violence in the study population. And IPV and mental disorders, especially depression, are important public health problems. And this is not only because of their high prevalence, but also because of their impact on health and quality of life, which poses a major challenge to the health services and systems worldwide. The prevalence of IPV is estimated to be higher in women than men and leads to considerable mental health problems. And WHO has reported that 1 in every 3 women has suffered IPV. And there's a reference there, did show a bidirectional association between ever exposure to IPV and depressive symptoms and alcohol use. And therefore, this makes IPV a significant mental health problem. And there is need for more evidence-based research to document this relationship. So the objective of this study is to estimate the prevalence of IPV among patients seeking care for depression and PTSD, or both, in a study that was conducting treatment for non-specialized delivery of psychotherapy, IPT, and or medication fluoxetine delivered by nurses for major depressive disorders and post-traumatic stress disorder integrated into the public sector outpatient primary care clinics in Kisumu County Hospital. And again, this was also part of yesterday's presentation. So the data is derived from the SMART DAPA study, and it's a randomized study with 2,162 patients from the outpatient clinics in Kisumu County Referral Hospital who screened positive of MDD, PTSD, or both. And the scale that was used to screen IPV was the Revised Conflict Tactics Skills, CTS2, by Strauss et al. 1996. And this is a 39-item scale measuring both the extent to which partners in a dating, cohabitating, or marital relationship engage in psychological and physical attacks on each other, and their use of reasoning or negotiations to deal with conflict. And it has 5 scales, composed of 5 scales, each of which has subclass. So the 5 skills are negotiations, psychological aggression, physical assault, sexual coercion, and injury. And it was administered among partnered participants. So the participants were partnered. As was mentioned yesterday again, the recruitment was through health talks, posters, referrals from OP clinics, word of mouth, that is peer-to-peer referral. And from the baseline, in terms of the participants, we had more females than males when we both are combined. So that and that tells us that in terms of IPV, then we have more females. So this shows the type of more. We have those ones who are, we had also HIV, those who are HIV positive, those who are negative, and Again, that shows the people who had intimate partner violence, but the types of trauma that were experienced. So those who had the different types of traumas, that is type 1, 2, or more, and this will also be explained further. So we'll have the discussion that will continue with the lead IPT provider.
So the action that were taken were, we linked our participants to social workers and the legal authorities, plus FIDA and children department, chiefs through social worker, nyumba kumi. Yeah, so that is one of the what we used to do. Another thing, we took them to safe homes because their life was not, they were not safe wherever they were they were staying, because they were staying with the perpetrators that were making them have depression and post-traumatic stress disorder. So another thing we also did is the interpersonal psychotherapy made them to reunite with their relatives as as their support system. As you know very well, that depression usually happens when you do not have people around you. So the moment you have people that can help you, the depressive symptoms will reduce. So another thing IPT, which is interpersonal psychotherapy, did was improve communication. It improved their communication. Okay. So just as I said earlier, one of the things we did again was also to we did reunite them with their relatives and their support system. And I said earlier that, you know, when depressive symptoms usually occur when you do not have a support system. So we really made sure that they maintain the relationship with their support system. And also, if they had conflict with their support system, we help them also know how to communicate assertively. So IPT, interpersonal psychotherapy, improves interpersonal communication. Just as I've said earlier, the way it did it, for example, it helped a participant communicate and maintain firmer boundaries when dealing with one particular person in their life with whom they are experiencing challenges. And this really helped them a lot. Thank you.
So in say that Smart Dapper study was a very huge study, and in as much as our major goal was non-specialist treatment of depression and PTSD, where there were also a lot of correlated factors. Some of them were the IPV, there was suicidality, there was the homicidality, and when we flagged the IPV cases, the homicidality, the suicidalities, we had to do what we call risk assessment so that we are able to help these patients. We are able to find a solution to them with their problems. And what we did was to really explore a lot of referral networks. We realized that there was a lot of gaps because we thought with gender-based violence, we were covered with gender-based violence spaces or homes. But when we got there, we realized that they only cover people who go through sexual violence. And ours mostly was physical violence and emotional violence. So we had to look for partners. We had to network with a lot of people within the region. I'm happy that most of our patients, up to 40% were HIV positive. And with the HIV network, there's a lot of support systems. So for those ones, we were able to find ways where they can get income generating activities, where they were able to start their new homes, where they were able to get food, and even some of them got scholarships for their children. That was just for the HIV positive. For the HIV negative, we used places like YWCA to get them to stay there for a while when we try and explore other social networks on how we can take them to families or elsewhere where they can begin their lives. And it really worked. And even at some point, when the YWCA was not working, we had to talk to orphanages who will take these patients for a while, even though the orphanages were taking people who were 18 years and below. But we were able to successfully work on that with the social worker. So I want to say that the prevalence of IPV was very high because in every week of recruitment, we'll get up to 40% of cases. And we also have to highlight that there's a gap with safe homes. So this is something that we really need to look into clearly and keenly and ensure that this, in as much as we are addressing treatment for patients with mental health disorders, we are also able to support them in other areas of challenges, especially on IPV. Thank you.